Thank you for being so patient, and for everybody online, hopefully you've managed to rejoin us on a new feed. We've been struggling with technology, and I think my ineptitude as well, so I do apologise for that. So to recap, we've got our 50-year-old lady presenting with nausea, dizziness, lightheadedness, unsteadiness. And our first question is looking at how might the patient first make contact in your healthcare system. What I'd also like to think about is, as the responding physician, what would your initial thoughts be? So some of the things that our audience have volunteered so far is this patient alone? So is she safe? One of the things that we're looking at. Also thinking about, we're starting to get some ideas about causes. So thinking about the different systems that might cause this. Also thinking about severity and speed of onset of the symptoms, any other systemic signs of disease that are going on, thinking about triaging, and then obviously history and examination are going to come into it, but we haven't got this patient in front of us yet. And then we've got people saying about trying to rule out serious diseases. Does this patient need an ambulance to pick her up? So one of the things I just want to think about with you in terms of clinical reasoning is that a useful technique that we can use, as we're doing here, is to think about stopping after you've got the initial presentation and actually then thinking, what more information do I need to know, rather than diving straight in with your standard history questions. So rather than thinking, starting to ask lists of questions. And so for this lady, some of the initial thoughts might be about what could this be, but other initial thoughts can equally well be about her safety and what's the best place for her to be investigated. And so we're starting to look at some of those things. Have we got any other suggestions coming in online at all, or are we? Right. Someone wants to put TweetDeck up, or I'm not touching it.
No.
Great. So we know that we're not on our own here. That's lovely.
I need to get it up as a separate thing. Don't want to stop that. Where is human? Here we are, Toby.
So we've got some ideas here about, thank you, Toby, who's contributing, saying about this could be multifactorial and we need to think about the patient's own health beliefs, absolutely. We know that we're working, thank you. So thinking about, one of our QMEC colleagues has put stop and think, what do I need to think about first? So I think we've established that one of the initial things with this patient is thinking about safety, urgency, and I think perhaps a consensus that she needs to be seen face to face. This isn't one we can assess over the phone.
Mm-hmm. Good. Okay, so back to the one that is actually sharing here. Okay.
Okay, so the next thing that we want to think about is what further information do you require? So we're going to assume now that this lady has come into a healthcare setting. Now that might be the emergency department, it might be the general practice. I think for our purposes, let's assume she's come into primary care, general practice. And the reason for that is that means it's going to limit what we can do initially with her. So you'll be able to take a history, you'll be able to do some examination, you might be able to do some bedside testing, but it's going to limit what you can do. So what we'd like everybody to suggest is what other information they require, but we want you to justify why you're asking for that, so that we're not just thinking about lists that we've learned. So history and examination findings, yes. We want to know about her past medical history, but can people justify to me why you want to ask a particular question? And then we'll give you a little bit more information from her. Is it not showing?
This question, so let me go back. No. Back. Oops, sorry, it's not my event. And it's this question. So show corresponding. This one. That's fine. Okay. Thank you.
Lovely. Okay. So we're getting quite a few things coming in here. So are there meningitis signs? Does she have diabetes? So we're already starting to think about some differential diagnoses here. So to give you her next bit of history, so she explains that she's been feeling generally lightheaded and nauseated all the time since Saturday. You're now seeing her on Monday morning. She said she's had some marked dizziness and a sensation of the room moving if she stands up or if she moves fast. And that persists even when she closes her eyes. Lasts for about a minute or so, but it's on a background sensation of feeling lightheaded and sick. She hasn't had any episodes of losing consciousness, but she has felt on a couple of occasions like she might faint. So she's sat down and waited for a little while. She's not entirely sure that that helps particularly. She's feeling generally pretty grotty. Any other questions from the audience on Mentimeter or from Twitter about specific details that you want?
Does she take any drugs?
So why are you asking that? So the question that's just come from the audience is, does she take any drugs? And the justification is that the person asking is a pharmacologist. So what in particular about the drugs are you alluding to there?
Well, just in case it might be contributing to the symptoms, or has she got a condition which requires drugs?
Yeah. So one of the things that we'd like to know is what kind of medication this lady might be on, whether she may have started anything recently, stopped anything recently, taken anything unusual. So with this lady, she hasn't taken any recent over-the-counter medications. She's not on any herbal supplements. She takes antihistamines just in the summer months for allergic rhinitis, but she's not on anything at the moment, and she doesn't take anything else regularly. So some of the questions coming in, so people are thinking about ENT causes and is this vertigo? So she's told us that she does have a sensation of the room moving when she stands up or moves fast. But she has also had some lightheadedness as well, and she's finding it difficult to differentiate between the two. We've got someone asking here about preceding illness and dehydration, and she has had a cold in the last couple of weeks, but that had settled down pretty well. We've got someone asking here about meningitis signs. We will come on to that. Does she have any diabetes? No, she doesn't have any history of that. We'll come along to examination things in a minute. We've got someone asking here about recent use of alcohol or recreational drugs. She drinks socially, as she puts it, which is anything up to a couple of glasses of wine, possibly once or twice a week if she goes out with friends. Quite often it's less frequent than that, but no more. Meds, e.g. antihypertensive. Note, she's not on any other medications at the moment.
Has she been eating normally?
She has been eating normally. So the question was, has she been eating normally? She's been eating normally up until Saturday when the symptoms started. And since then, she's felt too sick to really eat properly. So she's managed to nibble on a few slices of dry toast, and she's kept down some water, but she hasn't really been eating anything else.
Has anyone in the house or anyone who knows got the same symptoms?
Okay, so the question is, has anyone in the household or anyone else that she knows got the same symptoms? Not that she knows of. So she doesn't know of anyone else with the same thing at the moment. some of the other questions on here. So we've got people asking about any meningitis signs. She isn't complaining of a headache, and she's not complaining of any neck stiffness, but she is complaining of a feeling of a sort of fullness and a vague pressure sensation in her head since it started. She's not describing any photophobia.
Question from the audience: has this occurred previously, or could it be Meniere's disease?
Okay, so has this occurred previously? Could it be Meniere's disease? It hasn't occurred previously for this lady, so we don't know yet whether it could be Meniere's disease or not. We've got. Does she? So, question from the audience: does she smoke? No, she's a non-smoker, lifelong non-smoker.
Does she have any family history of cardiovascular diseases or cerebrovascular accidents?
Okay, so a question again from the audience: does she have any history of cardiovascular or cerebrovascular problems? And she tells you that her mother has hypertension, but she's never had any heart attacks or strokes or anything like that. So mother has hypertension, but that's all. Can I ask why you're asking about cardiovascular things? What is it in the history so far that's made you think about that?
The sudden onset, the morning onset of the vertigo, along with the nausea and vomiting, makes me think of a pontine stroke.
Okay, so we've got somebody coming up with a differential diagnosis here of something like a posterior circulation stroke, pontine stroke, because of the sudden onset, and so wondering about any risk factors for that. Okay. What have we got coming in on Twitter?
Okay, we've got nausea, vomiting, tinnitus, earache, speech problems, weakness. So we're treating the things that you've been saying.
The things that, right, okay. So she doesn't have tinnitus and she doesn't have hearing loss when you ask her about it, but she does have nausea. She hasn't actually been sick, but she's felt sick.
Any questions on Mentimeter if you go down?
Look.
So, yes, how? Any nice
Okay, any nystagmus? So we're going to come on to examination in a minute. Let's finish asking her questions first.
What else was there? So someone asked about an ECG. Any arrhythmias?
Okay, so the sorts of things people seem to be thinking of then so far are neurological conditions, thinking about neuro or ear conditions, also thinking about the possibility of cardiovascular conditions, and then obviously needing to rule out any other red flag things like infections, meningitis, encephalitis, something like that. Any other things that our audience can suggest?
Did she have her head recently?
Okay, so we're thinking about whether there's any history of head trauma, and note she hasn't hit her head recently. Why are you wondering about head trauma?
Just in case you might have hurt her head and that precipitated. Yeah.
Yeah, so thinking about possibly a concussion, post-concussion syndrome, or maybe a bleed or something like that. But no, she's had no head trauma. We've got someone asking here if she's got any visual problems. She said she's having trouble focusing on things. She feels like her vision is double at the moment. Have we got any other history things coming in on Twitter?
Anything else on Mentimeter?
Okay, so I think people are probably exhausting some of their history suggestions. So what sort of examination might you like to do with this lady? We've got some suggestions on here. Anything from the audience about what you'd like to do first?
I'd like to check her blood glucose.
Okay, so we've got a blood glucose as a possible suggestion, and why are you wanting to check a blood glucose?
In case this could be hypoglycemia.
Okay, so this could be an initial presentation of a hypoglycemic episode. We don't know of any diabetes in this lady, but it's possible that she could be hypoglycemic. So it would be reasonable to do something like a finger prick blood glucose measurement, because we're in a general practice setting, so we can't do a venous glucose. Is there anything else that anybody would like to do before we stab this lady? Okay, so we might want to do a neurological examination. Any particular bits of the neurological examination you'd like to do? Okay, and are there any particular cranial nerve problems that you're anticipating or potentially anticipating? Okay, so we've got from the audience that we would want to look for nystagmus. Again, we've got that on Mentimeter as well. And what might nystagmus tell us? Okay, so we're thinking about nystagmus as being a symptom of possibly something happening somewhere in her ear, so in her inner ear.
GPs always do blood pressure.
So it's coming from the audience, thought GPs always took blood pressure. We do, so we probably would. Any particular things about the blood pressure that we might do?
I was just looking for any abnormal pulse and pressure.
So we might look to see if her blood pressure was generally low. Any other things that we could look for with her blood pressure?
Wide or narrow pulse pressure.
We might look for a wide or narrow pulse pressure. What would that be telling us?
Any cardiac origin.
So we're thinking then of cardiovascular causes of this. Any other suggestions? Anything online for what we could do with her blood pressure?
If it was raised, it could be a risk factor for stroke.
Yeah, we've got people talking about risk factor for stroke if the blood pressure is raised. So her blood pressure with her sitting next to your GP desk is 110/64. Her cranial nerve examination, because somebody asked about that. She's got smooth eye movements. She has a few beats of nystagmus at the extremities of her gaze. She doesn't have any other cranial nerve abnormalities that you can detect. She can hear when you rub fingers equally well bilaterally.
Based on that, I would also like to do a cerebellar examination.
Okay, so we've got a suggestion from the audience that we'd like to do a cerebellar examination. So what would you like to do?
I would like to see if she's how her gait is. If she has an ataxic gait.
Okay, she has an unsteady slow gait.
Is it broad based?
She takes a few normal steps and then she's slightly broad based and staggers slightly to one side. So she's struggling a bit. She's complaining of feeling very sick. And could she sit down, please?
She wants to also check for dystokinesia.
Okay, so we've also got a suggestion from the audience about checking for dystokinesia, which is fine. Okay, so we've got a suggestion about Weber's and Rennie's test. Why would you like to do those? Okay, so we're thinking about testing possibly for sensorineural hearing loss. She hasn't complained of any hearing loss, and you do those tests if you've got a tuning fork in your room and they're normal.
Her speech, is there any abnormalities in her speech at all?
Okay, so a question again from the audience about any abnormalities in her speech, and as far as you can tell, no abnormalities in her speech. She's come in on her own, so you haven't got any collateral history.
If we did a upper and lower limb examination, I wonder how her tone is.
Her question again about the tone on an upper and lower limb examination, her tone is normal. Any other questions that we've got coming in online? No hearing loss. So. lying and standing blood pressure is coming in as a suggestion online. We've got a lying blood pressure of 110/62, which is pretty much the same as her sitting blood pressure of 110/64, and her standing blood pressure is 102/64. So what I'd like to do at this stage is just get everyone to think about what we know so far, and see about how that might be refining your diagnosis. So just to summarise with this lady, 50-year-old lady, sudden onset of dizziness, nausea, a bit of lightheadedness, feeling unsteady on her legs. We've established that she was just about able to come into the GP surgery. So she's in the GP surgery. She's spoken to the GP and said that this has been going on for a couple of days. She's felt sick but hasn't been sick. She's managed to eat a little bit of dry toast and have some water, but nothing else. She hasn't had any hearing loss or tinnitus. She had a cold in preceding weeks, but that had settled. She's got a vague pressure sensation in her head, but no other symptoms that would be suggestive of meningitis. She doesn't describe anything like photophobia or neck stiffness. She feels generally weak and wobbly, but hasn't noticed any loss of function in her arms or legs. She's not on any regular medications at the moment, hasn't taken anything new over-the-counter herbal or recreational drugs, doesn't smoke, drinks social alcohol, so 1 or 2 glasses of wine a couple of times a week. And then we've got some examination findings that she's got a blood pressure of 110/64 when she's lying down, similar when she's sitting down, 102/64 when she's standing up. Her cranial nerve examination is normal. Upper and lower limbs have got normal tone. Her balance is not great when she's walking, so she's unsteady, slow, staggers off to one side a little bit. She's got normal dysdiadochokinesia test, and I think that's as far as we've got at the moment.
Could you consider cranial nerves 5 to 8, someone's saying?
Yeah, so if we examine those, that's certainly a good suggestion. They're normal.
How's the vertigo when she's laying down?
She said that she gets it if she moves fast when she's laying down. So the question was, how's the vertigo when she's laying down?
Was it blood glucose normal?
Blood glucose was normal. So we've got something on here on Mentimeter about still concerned about a posterior circulation stroke. So let's throw that one open to the audience and say, is there anything in particular that you would like to do in terms of investigating that? Sorry? So question about asking about visual field defects. No, that's normal. Although she's struggling to actually comply with it because it's making her feel sick. So we haven't checked her temperature yet, but when you check it, it's normal.
In the audience, does the vertigo begin with head movements?
So the question from Twitter is, does the vertigo begin with head movements or latency? So she does notice it if she moves her head fast, but she also notices a sensation when she stands up. So yes, she does get it with movement. We've got a question here on Mentimeter about any discharge from the ears or fever. So we've said no fever, and you have a look in her ears and she's got clear auditory canals, and she's got normal tympanic membranes both sides with a good light reflex. So we can see so far that the questions that we've been getting in, again, fit with this kind of thinking about cardiovascular causes, thinking about neurological causes, thinking about ear-related causes. So we've been investigating whether she has hearing problems, which she doesn't seem to. We've been investigating whether she has balance problems, which she does seem to. We've done a little bit of investigation about cardiac problems with her blood pressure. Thinking with those along those lines, are there any other investigations, any other examinations that you would like to do?
Well, we have the facilities, ECG we do.
Okay, so we've got a suggestion from the audience about an ECG, which some GP surgeries would be able to do. So if you could perform an ECG, that's great. And this lady has a normal ECG. Her pulse rate, which shows on the ECG, is 90 beats per minute, but it's otherwise normal in terms of the trace.
This might sound a bit far-fetched, but I'm wondering if we could possibly see she responds to an Epley maneuver. Okay,
so we've got a suggestion from the audience about performing an Epley maneuver for this patient. So what are you thinking about there?
I think a benign position vertigo.
Yeah, so we've got a suggestion of BPPV, or benign positional paroxysmal vertigo, or benign paroxysmal positional vertigo. And that's a common cause of vertigo. So it would be very reasonable to do something like a Dix-Hallpike test, so a positional test to look for any nystagmus and sudden onset nausea and vertigo when you do that. When you perform that test, she does feel sick and dizzy with it, but it's not she closes her eyes, you can't see any clear beats of nystagmus, so it's not an absolutely conclusive test.
Very real, isn't it?
Yes, this is very real. So she's getting sort of some slight positives for some of the tests, but nothing, absolutely diagnostic so far.
What's a GCS if she well orientated?
So good question again from the audience about her GCS. Yes, she's alert, but feeling horrible. But yes, she can answer your questions. She's not compromised in terms of her conscious level. Have we got anything coming in on Twitter? Yeah, so just to recap then for everybody. So she's got symptoms of dizziness, nausea, unsteadiness, and a feeling of the room moving, so a sort of vertigo feeling. No medications. She's getting the sensations if she moves suddenly, if she rolls over, when she stands up, and she's got a background feeling of being just generally unwell, weak, and a bit lightheaded, but definite episodes of what sounds more like vertigo on top of that. She hasn't described any limb weakness, but she is unsteady on her feet, with some signs that may potentially be cerebellar, though not absolutely clear-cut. Thinking about ear causes, particularly inner ear causes, she has some symptoms on a Dix-Hallpike test for BPPV, but again, not an absolutely clear positive on that. She doesn't have any other cranial nerve abnormalities. She's got a normal pulse rate or slightly high at 90 beats per minute, but certainly not a raging tachycardia. Her blood pressure is 110/64 lying, 102/64 when she stands. So she's got a very slight postural drop in her systolic blood pressure. But again, nothing major. Her ears, when you look in with an otoscope, are absolutely normal. She's afebrile. And I think that's as far as we've got so far with examination. She's got a normal blood glucose.
We're going to have to deal with clinical uncertainty.
Mm-hmm.
If I ask one more question.
Of course, yes, please do ask questions, yeah.
Does she have a history of migraine?
So question again from the audience, does she have a history of migraines? And so are you thinking here of migraine-related dizziness symptoms? Yeah. Yeah, no, she doesn't have a history of migraines, but again, that's another cause that would be worth ruling out. So with some of the clinical reasoning here, you can see that what we're doing is we're starting off with some fairly broad differentials, and we're starting to try and narrow down a little bit. We haven't narrowed down that far yet, but we're starting to look at what it may or may not be. So does anyone feel that we've ruled out anything that they were thinking of? I can see some nodding from the audience. Yes, no.
Unlikely to be meningitis.
Okay, so we don't think this is a meningitis now, so that's one of our red flags kind of out the way. Yeah.
Unlikely to be an acoustic neuroma.
Okay, so we've also got a suggestion that it's unlikely to be an acoustic neuroma. Why is that?
Just because of how quick the history was. And
Yeah.
the fact that her examinations for your nerves were normal.
Yeah, so she's got a rapid onset of this, a sudden onset rather than a gradual onset. She doesn't have any hearing loss with it, and she's got normal cranial nerve examination. So things like an acoustic neuroma are less likely, so they're moving down our differential list. Is there anything that's moved up your differential list that you think is more likely with the examination findings and the history that we have so far?
BPV and pontine stroke.
Okay, so we're still thinking from the audience here that BPPV or something like a posterior circulation stroke might be ones to consider. Anything else from the audience here that you'd like to rule out still, or that you'd like more information about?
The subacute onset makes me wonder to do effective causes and whether it can be like just labyrinthitis or something like that.
Okay, yep, so we've got a suggestion from the audience that with this kind of onset, it could still be something like a labyrinthitis or a vestibular neuritis because she doesn't have the hearing loss. Yeah.
Have we absolutely ruled out something like food poisoning?
Okay, so we've got a question from the audience. Have we absolutely ruled out something like food poisoning? So I don't think we have yet. So are there any other questions that we might ask or any other examinations we might do to look at that?
How's the urinalysis?
Okay, so we've got suggestions yet. We might ask her about whether she's had any diarrhea, and she's not had any true vomiting, although she's felt sick. She's not had any diarrhea, so her bowels are opening normally. In terms of urinary symptoms, which is another suggestion from the audience, she's not noticed any frequency dysuria, so again, nothing to suggest a urine infection. Is there anything that you would like to do? Would you like to do anything like a urine dip or?
Urine dip would be.
Okay, so we might want to do a urine dip. We know that very often in women of this age, though, they would present with symptoms if they're going to have a UTI. It's unusual for them to have asymptomatic urine infections, but I think in this case it would be reasonable because obviously she does have some symptoms. What about cardiac causes? Sorry.
Like, given the normal ECG and normal findings on examination, it's unlikely to be a cardiac problem.
Okay, so we've got a suggestion from the audience that given a normal ECG and normal blood pressure findings, it's unlikely to be cardiac cause. We haven't actually examined her heart yet, but if we did, we'd find that she had normal heart sounds, no murmurs. So yes, we're perhaps suggesting this is less likely to be cardiac. What else have we got coming in from Twitter?
I realise this, yes. Okay, safety netting plus, managing uncertainty, but clear advice to patient and when and how to access help.
Okay, so we've got some comments from Twitter here. So this is thinking in terms of management now, that we're going to be needing to think about safety issues and safety netting of this patient. That's if she were to be sent home.
There's concern that she can't walk properly.
Okay, we've got concern from people that she can't walk properly. So any suggestions about management for this lady then? So we still haven't really whittled it down to a particular diagnosis. So we're going to have to think about dealing with uncertainty in terms of our clinical reasoning. So what would you like to do with this lady? What would your management plan be?
So yeah.
That's usually top of the list, isn't it?
So we've got our medical students in the room are suggesting that they would ask a senior for help, which is entirely appropriate. That's absolutely fine. What about the seniors in the room or the seniors out there on Twitter who don't have that luxury? We've got a suggestion on Twitter from some of the GPs that this could potentially be something along the lines of a labyrinthitis or vestibular neuritis, as we've had suggestions in the room. What would people do if they thought the patient had that? So, okay. So we might be talking about some antiemetics. We've had a suggestion of cyclizine. We might also use something like prochlorperazine if we're thinking about some kind of neuritis. We've got some management options coming up here. So you may be happy to send her home with some Stemetil and safety netting. And by safety netting, we mean clear instructions for what to do if this were to get worse. And also then some follow-up. So we may have some people who would send this lady home. We've got we've got a suggestion: refer her to someone that knows. I don't know if that's a criticism of the GP or whether that's just that somebody who has access to more investigations. So are there any factors in the history that would make you think that this lady might need referring on?
The fact that she's got such profound or significant ataxia, which has started so suddenly, I wouldn't be so comfortable in letting her go away.
Okay, so we've got a comment from the room that the ataxia, the unsteadiness is the worrying feature here, and so there's some discomfort about letting her go home. So it may be that we need to actually consider referring her to secondary care for investigation of a stroke. Yeah.
Could we find out if she's got somebody that could come in and go home with them?
Absolutely. So one of the aspects of safety netting, we've got a suggestion from the audience. Do we know if she's got anybody who could come in and be with her? So I guess we've got ideas here about how urgent is this, how severe might the pathology be, but also questions about safety and thinking about how safe would she be to go home, even if we were happy in terms of the pathology, that she, that it was a self-limiting condition.
Is she now dehydrated?
So got a question again from the room about whether she might be dehydrated. She's got a pulse rate of 90 and her blood pressure systolic was 110. So she might be a little dehydrated, but she's certainly not got dry mucous membranes or anything like that.
Is there a difference between the blood pressure from one arm compared to the other?
So when she has her blood pressure measured in each arm, it's roughly the same. Okay, some questions from Twitter?
One, I'd like to ask the patient if she thinks she can manage the home and how. And the second, if we think there's a possibility of the CVA, it might need an onwards referral.
Okay, so we've got some input from Twitter that one of the things that we need to consider is whether the patient would feel that she was able to go home. So if we felt that this wasn't something that needed management in hospital because of the pathology, we might still need to consider whether she was actually safe to go home on her own, and whether we did need to refer her on because of the risk of stroke here.
Nice question here. There's so few symptoms. Does she have a psychiatric history? So few signs.
Okay, so another comment from Twitter about she's actually got fairly few signs, and could we be considering something like a mental health cause or some kind of mental health involvement here as well? And we know that quite a large percentage of people that do present with dizziness, we don't find a cause. Okay, so we've got again from Twitter about should we be seeking an ophthalmology opinion? Does it say any more about why that might be? Okay, so what I'm going to do, because that clock's not working, because time's getting on, I think we will wrap up where we've got to so far with this lady. And maybe then people could just plump for whether they think this lady needs to be sent into hospital or not, because I think that's the key primary care decision that you need to make at this point with this lady. Is she safe to manage at home, or does she need to go into hospital? So what our clinical reasoning has done is it's actually got us to a point where we're thinking about a management plan, even though we don't have a diagnosis. And that's very common in primary care. So we've got this lady with features that might be suggestive of something like BPPV, with some features that might be suggestive of something that we can do less about, like a vestibular neuritis, where she could go home if she was going to be safe at home. But we've also got some queries about whether it could be something like a posterior circulation stroke, and we don't feel that we have enough information at this stage necessarily to rule that out from some of the contributors. Some people may be happy to send her home and safety net and bring her back in if things aren't settling. Shall we do a show of hands in the room for who would admit this lady? Okay. So in our room, we've got probably about half the people saying they would send her in. Who would let her go home with careful safety netting? So again, about half of our, that's quite good. We haven't got anyone abstaining particularly. So, so about half of our audience here have said they might let this lady go home with careful safety netting. Okay, any thoughts on Twitter?
Some thoughts about viral labyrinthitis.
So we've got thoughts about viral labyrinthitis, so probably in that situation they would let her go home.
Have we discussed our clinical reasoning and our concerns with the patient yet?
Okay, so there's a very good question from Twitter here saying, have we discussed our clinical concerns and our safety netting, our thoughts with the patient and sought her opinions on this? And certainly that's something that I think is very important. One of the good things is if you can be explicit in your clinical reasoning with patients, then we know that they're more likely to adhere to management plans because they've agreed them with you. So with this lady, I think it would be very important to say, these are the possible things I'm considering. We know that it's statistically, in terms of probability, more likely to be something like BPPV or neuritis, vestibular neuritis. But, you know, we know that for an individual, there's still a risk of it being something more serious. So you can't just go on probability. It may be that you decide you want more features in terms of history or examination if you had longer with this lady. So lots of things that we can think about there. Any other final thoughts from Twitter before we wrap up?
A question. If she was to go to hospital, go through a certain pathway, or what would we do?
Okay, so a question from Twitter about what might we do, or what might the pathway be if this lady did get sent into hospital. And again, I think that's probably something that varies depending on where she might be. And so some places we might be able to send her in for, refer her in through a stroke pathway. Some places she may not meet the criteria with her current symptoms to go straight to a stroke pathway, and so we may need to think about other options, may need to discuss with a stroke specialist or a neurologist or somebody else to find out how we would get her seen in secondary care. Last question from the audience.
Since the morning until now, the conversation, has the symptom changed at all?
Okay, so question about, has there been any evolution of the symptoms since they came on? And no, they've been pretty much the same. Does that help you with your reasoning on your sort of likely diagnosis? No. Okay.
Yeah, it's kind of slightly against the posterior circulation stroke, but still not entirely. I'm still kind of putting that out.
Okay, so again, just questions asking about, you know, is there any way we can try and differentiate, and possibly with stroke we may see evolving symptoms, we may not. Okay, so I think what we'll do is wrap up, go to our last question. Can we activate the next Mentimeter question? So we'd be interested to know what people's take-home messages are from this, and I'm quite deliberately not telling you a diagnosis, because at this point, with this lady in front of you, without any more information, with tests that we can't access with this lady sitting in front of us, we don't know what the diagnosis is. And I'm going to leave you with that frustration and clinical uncertainty, and just remind you that that's what GPs deal with on a day-to-day basis, on a case-by-case basis very often. And we do have to deal with uncertainty, and you may find that you refer one person in and the next person, there's a slight difference in the history and you don't refer them in. So it's very important to think about your clinical reasoning and think about what information that gives us and what we do with it. So our final bit for today is just to thank everybody for taking part. Apologies if it's been a bit stilted at times. It's quite a juggling act to look at Mentimeter and Twitter input and think about the audience as well, and deal with technology that we're slightly unfamiliar with. So thank you to everybody for your patience. We'd love it if you could just share with us some take-home messages and how useful this might be as a clinical reasoning process. So we're getting a couple of things in on Mentimeter so far, thinking about ensuring that you follow up patients after you've seen them. So the importance of safety netting. How do GPs deal with the unknowing, with the uncertainty there? It's useful to follow up patients a bit later so you know what happened in the end. Thank you, great session. Don't get too frustrated with not coming to a specific diagnosis. And that's one of the reasons that we tend to refer to clinical reasoning now rather than clinical diagnostic decision making, because it's not all about a diagnosis when you have a patient with an undifferentiated problem like this. Certainly not in the first instance. Yeah, comments about it's important to feel comfortable if you're letting someone go home, to know you have a plan in place. Yep, not every T needs to be crossed, nor can it be. We work within limitations. So someone's saying here it's a really useful session, but they really want to know the diagnosis. Sorry. So yes, think about the patient too, management, safety netting, and not necessarily just the diagnosis. So it's sorry. This is loosely based on, this is based on an amalgamation of typical patients that we've seen with dizziness and these kind of symptoms. So this could be a very real patient that walks into your door, but we're not going to have anybody particularly complaining at us for sharing their one case.
That was one of the ideas behind running this case, is because we're so, as students, we're always looking for a diagnosis of differentials and
Really tough.
It's one grand randomization to have a diagnosis or a new phenomenon.
So we've got a couple more comments here about the importance of ruling in or out differentials via a systematic approach. Sorry. Sometimes you don't always have a diagnosis straight away. It can take a while. Yep. No diagnosis should be one of the differential diagnoses. Absolutely. Question here saying, oh, have we really ruled out something nasty? You might think it's likely to be, I think that's viral, but can you be sure? And that is one of the key things about primary care, is that you always have that risk of, gosh, what if I missed something? Won't sleep till we know the diagnosis. Yeah, welcome to the world of GP insomnia. Okay, Rajiv, would you like to say anything at the end to everybody?
I'd like to thank Dr. Boardman and Dr. Leading Green too for giving up the time today and delivering a great session. There were a few teething problems at the start, but I've been getting messages from different countries, and here's the one from someone at UCSF. Had to run to a meeting, great work there. I think this is a fantastic idea and a great way to get med students talking around the world. And just some final comments on Twitter. Well, from the audience, great to think about interaction between disease process, social situation, and patient ideas and risk management in primary care. And from Toby, he's contributed from Newcastle. Great discussion, useful to take a systems approach, rule out the serious pathology, then safety net. Pass it back to Dr. Boardman.
Great, thank you very much. Just a final thank you to everybody in the audience for being so patient, and particularly as I know the eye contact maybe hasn't been there to the same extent as it would be if I didn't have all the technology going on as well. Thank you to Rajiv for inviting us, and to the team at the Gordon Museum and at King's for hosting us here. I'm hoping that this will be the first of more sessions like this, hopefully with perhaps the involvement in the future potentially of patients as well getting involved in the discussion, and I think this is something that we could expand further. So congratulations to Rajiv, well done. Thank you to all who've been involved.
So I'd say one final, a big thank you to Johnny Neville, who's been conscientiously typing up on hashtag GKTMedEd. The reason I wanted to do this is really to inspire the younger students here to carry this on, getting a new curriculum and having these new ideas, and incorporating technology where it does work, because it doesn't always work. And I guess we found that out today, but it was a pilot, and it was great to engage with everyone online. And thanks very much. And as Dr. Boardman said, I think it's intrinsic that we do have the patient in the room, because having all models of care centered around a patient, and that's something I've learned, especially during my primary care placement, which has really helped me realize why I applied to medical school, and just being easy with that uncertainty, which is so common in so many situations, and we're always eager to look for diagnosis.
And just to anybody who's still squirming at not knowing the final diagnosis, because I can see quite a few comments coming in on Twitter, what I would suggest is that it's worth spending some time looking at some things about cardiovascular causes of vertigo and dizziness, or lightheadedness and dizziness, thinking about your neurological causes of it, your ear causes. You might find features in this history that point you slightly more towards one diagnosis or another, that might help you with the question of whether or not you send this patient in, but we're still not going to tell you.
Just get Johnny up to the front of the stage.
Hello, thank you very much. You've been listening to me on Twitter all of the evening. I'd just like to say thank you very much to Kerry Boardman, Rajiv Sethi, the Gordon Museum, Bill, and everybody here for hosting this session. We look forward to many more sessions in the future. I'm also a bit sad that we don't know the diagnosis, but I'm going to go home and read about neurological and cardiovascular causes of dizziness and nausea. Thank you very much.
Hand it back to you. Close down the presentation. Thank you.
Thank you very much.
Thank you, everyone.